If I jump off, it'll still keep going. So don't worry. Like if I lose my signal, you'll be fine. All right, my love, we are live. I'm about to start the recording. Can I do it? Wait a minute. How can I do it? All right, we would like to thank you, Dr. Rosette, for joining us today. This is our final Saturday of the Health and Wellness Summer 20 Kusudi Health and Wellness Lecture Series. Dr. Rosette is a board member of Kusudi International. She hails from Carmine, California, LA, and she is a Howard graduate and a USC graduate. You know, HU is in the building nationally and in the house. And so we're really happy to have her. So I'm going to turn it over to you, Dr. Rosette. Thank you so much for joining us today.
Thank you so much. Thank you so much, Dr. Mensa. I am so honored to be here today. The work we're doing over at Kusudi is such great work, and programming like this is definitely what the community needs to be able to advocate for themselves. So to go ahead and get right into it. Today we're going to be talking about comorbidities in the senior population, knowing the effects of age-related muscle wasting. And as she said, my name is Amanda Rosette, hailing from the great city of Los Angeles, California. Today's objectives will be, number one, define sarcopenia. Number two, discuss the prevalence of sarcopenia. Number three, examine the major causes of sarcopenia and discuss the management of sarcopenia. Aging is a gift that keeps on giving. It really is a gift because we would all desire to, make it to our old age and spend as much time with our families. But I like this quote from Katharine Graham. It says, "No one can avoid aging. The aging productively is something else." And so really the goal is to age gracefully, age productively. So that's hoping with this information that's something that we can try to get everyone to be able to do. So sarcopenia. Sarcopenia is the age-related gradual loss of skeletal muscle and strength. 2010 European Working Group defined 3 stages. Number 1 is pre-sarcopenia, which is simply just the loss of muscle mass. Number 2 is sarcopenia, the loss of muscle mass that occurs in conjunction with loss of strength or physical performance. So I know you're like, well, how is it possible to lose muscle mass but not also lose strength? Because muscle mass and strength is not always a linear relationship. So it is possible that you can lose muscle mass, but your strength is measuring normal because other factors actually go into strength we would kind of get into a little bit later, such as molecular nutrition and things like that. So that's 3. And number 3 is severe sarcopenia, where you have a loss of muscle mass, and also physical performance and strength. So that means basically your strength is also now measuring weaker, but you're also now having difficulties with things like going up the stairs, sit to stand, things like that. A gradual loss of muscle fibers begins at age 50, and approximately 50% of the fibers are lost by age 80. Strength declines by 10 to 15% per decade. Up to age 70, the loss accelerates to 25 to 40% per decade after that. It's one of the leading health issues in older adults, which increases disability, risk of falls and subsequent injuries, hospitalization, loss of independence, and mortality. This is just a visual that actually just kind of shows some of the things that I touched upon. Once you lose that loss of muscle and strength and function, that leads to sarcopenia, which then puts you at higher risk for these things: increased risk of fall, disability, mortality, morbidity, loss of independence. And really in my work with seniors, I think the biggest thing that they struggle with is that loss of independence. Oftentimes we know that the seniors in our life, they're used to doing everything on their own and being independent. So really when they start to lose that strength, and have to deal with that loss of independence, that it has been one of the things that has been really difficult to them that I've seen in my practice. So prevalent. Overall prevalence is 10% in both men and women over 60 years old. Some studies, you can find the prevalence being anywhere between 5% to 50%. But a systematic review actually looked at a lot of different studies, and they kind of came up with this overall prevalence, 10% in both men and women over 60. And when you further begin to examine prevalence, you look at community dwelling individuals, which are individuals that are still currently living in their own personal home. And that goes to 11% in men, 9% in women. When you examine people that live in nursing homes, and you can assume people in nursing homes have a lot more disease processes that they're going through. They're a lot more, they are more sedentary and maybe not able to do as much as other individuals. So that actually raises the prevalence up to 51% in men, 31% in women. In that same vein, in the hospital, usually there is a temporary period of immobility, and that can definitely lead to decreased strength. So in that case, it's 23% in men and 24% in women. As far as the age is concerned, the mean age in men is about 70.5 years old, and the mean age in females is 71.6 years old. So really in that 7th decade is when you start to kind of see some of those changes. Assessment and screening. Again, the research says a lot of different things, a lot of different ways to diagnose it, but this has kind of been general consensus that you see here in this algorithm. So they start with this individual over 65 years old. They measure the gait speed, how fast they're able to walk. If that speed is, we'll go ahead and go down the left side of the algorithm. If that speed is greater than 0.8 meters per second, then they measure the grip strength. If that's normal, then they can kind of rule out sarcopenia. If that's low, then they go to begin to measure muscle mass. If that's low, they can kind of rule in sarcopenia. If that's normal, then perhaps again, they're ruling out sarcopenia. Of course, comorbidities and individual circumstances, needs to be considered as well. Let's talk about what kind of causes this sarcopenia. So it really is a multifactorial disease. So increased inflammation, age-related molecular changes, decreased activity and nutrition, decreased motor neurons, hormonal changes are some of the things that actually contribute to a person developing sarcopenia or this age-related muscle wasting. We'll go ahead and talk about a few of those causes. We'll start with low activity. You guys all have heard it before. If you don't use it, you'll lose it. It's true. It is very true. Inactivity, even for a short period of time, can lead to decreased stimulation, muscle protein synthesis, which is the process the body requires to repair, grow, and strengthen muscle fibers. This can result in a decreased muscle mass and strength. Inactivity can also lead to changes in muscle fibers. Those are the fibers that makes up actual muscles. So it decreases the type 2 fibers, which are larger and they produce more tension. Then it increases the type 1 muscle fibers, which are smaller and low tension producing. So when you have something like that, the muscle fibers that you do have, they're not able to produce as much tension, generate as much strength. And so, of course, when you have that happen, that can also kind of lead to a decreased strength. Again, this is just another algorithm that shows different things that activity on the left side can lead to. Insulin resistance, antibiotic resistance, which is that blunted muscle protein synthesis, again, which is what the muscle needs to repair, grow, and strengthen the muscles. Hormonal changes is another thing. Androgen levels decline with age in both men and in women. Beginning at age 35, testosterone levels in men increase by 1 to 3% per year, while women has their biggest drop in estrogen during menopause. Decline in both testosterone and estrogen, respectively, can lead to muscle mass and strength loss. Nutrition with low activity is actually two of the biggest factors that have been studied when it comes to sarcopenia, and definitely two of the biggest things that we like to center intervention around, which is something we'll talk about a little bit in greater detail in a moment. So among older adults, food consumption has been recorded to be reduced by 25%, with subsequent decline in the quality of food. So not only are older adults eating less, they're also not eating well-balanced meals at times. And so whereas they used to maybe have ate whole foods and fruits and vegetables, now maybe they're eating a little bit more processed food, things that they can make on their own. It doesn't require a whole lot of cooking, and that can sometimes be consistent with the quality of what they're eating going down. With aging, inflammation, and disease, a higher intake of protein is needed to maximize the muscle protein synthesis. So in older adults, their muscle protein synthesis is blunted. So that means they require a higher level of protein and amino acids, that building blocks of protein, go ahead and to stimulate that muscle protein synthesis. For example, whereas a younger person may be able to eat maybe 5 grams of protein and stimulate protein synthesis, maybe an older adult would need to eat about 10 grams of protein to initiate that same process. Low vitamin D status is associated with increased risk of falls and proximal weakness. I know you're like, oh my goodness, this lady told me I'm gonna be so weak by the time I get old. What can I do about it? Don't worry, we are gonna talk about that so you can live your best life in your golden years. So let's go ahead and talk about how we're gonna manage sarcopenia to be able to kind of be as strong as we can as we age. So in general, an appropriate exercise regimen accompanied by nutritional interventions are two major components leading to better outcomes sarcopenic and geriatric patients. So because these are the two major components, this is kind of where I am going to focus the presentation on today. So exercise. The biggest type of exercise that has been most studied and found to be kind of most effective for sarcopenia is resistance training, which means exercise that you're doing against a load. A study done by Buckwheat et al. States that high intensity resistance exercise programs are best for sarcopenic patients. He recommends 1 to 4 sets of 8 to 15 repetitions 2 to 3 times a week. And of course, the weight or the load that you're using is individualized, something that your physical therapist or personal trainer can start with you, start at a low load, and then increase as you guys go along. So that is individualized each person. Aerobic exercise, also another type of exercise that has shown to be beneficial for sarcopenic patients. Aerobic exercise of skeletal muscle induces ATP production, which is a molecule that carries energy around the cell. It has been shown to induce more of that ATP production in different parts of the cell, which enhances aerobic ability, metabolic control, and cardiovascular function, thus providing a protective effect of the skeletal muscle, making them more efficient, being able to use more energy to be able to do their function. Another study by Harbour et al. Recorded that cycle exercise, such as biking or pedaling, in both 20-year-olds and 74-year-old subjects improved muscle size and strength. Multimodal exercise. This is a kind of exercise as a physical therapist that I like to do because we know that nothing happens in a vacuum. If a patient is losing strength, most likely they can lead to loss of decreased balance, which can lead to an increase in falls. So definitely older adults, we know that 1 in 4 adults over 65 is falling. And so that's something that we want to make sure that we're trying to address at all times. And so really this mix of strength training, cycling and or aerobic training, balance training, etc., is really where I like to put my focus in, so that I'm making sure that any patient that I see is really getting a comprehensive program that's addressing all aspects of their physical function at one time. A study by Lee et al. Reported that 12 weeks of circuit programs involved walking, balance, and muscle function. I'm sorry, improved walking, balance, and muscle function. I'm sorry. Hold on. Okay, there we go. So I've included some sample exercises that can be done. These exercises are usually are safe for the most part for older individuals to do on their own, or of course, if they require more assistance with standing up or maintaining their balance, it's something they can do with one of their loved ones nearby to maintain safety. Sit to stand is probably my absolute favorite exercise to give my senior patients. It's very simple to do. It's something that they do every day in their normal lives, and it really works a lot of muscle groups that are needed to be strong for doing things like sit to stand or walking upstairs or maintaining good balance. And so that's just one that you just sit in your chair and you're standing up and down. Heel raises is another exercise where you're just standing up on your toes, standing up, excuse me, holding on to the chair. You're lifting up on your toes, making sure that you have really good, strong calf muscles is really important too with balance, because it's one of the mechanisms that you use when you're trying to maintain your balance if you kind of get unsteady. Standing hip abduction, that's something that strengthens up the hip muscles, which are very important in providing stability when you're standing, when you're walking. And so this exercise is another one. You're just standing behind the chair and moving your leg out side to side. Tandem stance is an exercise that is for balance, where you're putting one foot in front of the other. The one foot toe is touching the heel of another foot, and you try to just keep your balance. This one is a little bit more unstable, and so it may be better to have a loved one nearby to be able to do that, to be able to do it safely. And so these exercises are exercises that weight can be added, that can be progressively, that can be progressively harder with adding more reps or weight. Those are just some sample exercise. This is not the end all be all. It is a good place to start. Nutrition, excuse me. Protein intake is definitely one of the major things that we consider when we talk about nutrition in sarcopenic patients. Higher intake of protein is needed to maximize the muscle protein synthesis in older adults. So we kind of touched on that before, is because that is a blunted process in older individuals, do require more protein to initiate the same process that their younger counterparts would need less. Recommended protein intake between 1.2 and 2.0 grams per kilograms a day or higher is what's recommended for elderly adults, versus the recommended dietary allowance of 0.8 grams per kilograms for adults over 18. So if you think about you take 1.5 grams per kilograms a day in about 150-pound woman, you're looking at somewhere around the 100 grams a day of protein that individual would need. And if you look at 180-pound man at 1.5 grams per kilograms a day, you're looking a little bit around 115, 120 grams per kilogram a day. Another essential amino acid that is important for elderlies to have is leucine. It's an essential amino acid, which again is the building block of proteins, and it's the most potent one for stimulating muscle protein synthesis. And recommended amount for that is 1.2 grams to 6.6 grams per day, has been shown to be well tolerated and significantly improve sarcopenia, most notably lean muscle mass. So foods that's rich in leucine is chicken, tuna, firm tofu, beef, pork, canned beans, squash seeds, dairy, eggs. So it's not hard to get. It's, you just, I think as you increase your protein, usually you should be able to also get that increased amount of glutathione. Vitamin D. Vitamin D supplementation should be considered to improve physical performance and muscle strength in older adults. RDA for individuals over 71 years old, 800 IU up to 1,000 IUs have shown benefits, but not necessarily at higher doses. So if you want to say like, well, I'm going to take 2,000 IU worth of vitamin D just because I want to be make sure I'm getting enough, that's not necessarily going to any more beneficial than taking 1,000 IU, the studies have shown. So what's the bottom line? The bottom line, malnutrition and low activity seems to be the two major factors associated with sarcopenia. So prioritizing a well-rounded exercise program and nutrition made of healthy proteins and whole foods is really the best course of action that you can take to try to slow the progression of sarcopenia. Also, and oftentimes, sarcopenia has been shown to be largely reversible. So that's good. Any questions? Thank you guys so much.
I have a question.
Yes.
Thank you so much for the presentation. I was curious to know learn a little bit more about your perspective as a physical therapist and kind of the population that you treat. What do you typically see in some of the older patients that you have to rehab, and how is that correlated to kind of what we talked about today?
Yes, definitely. So I've been a therapist for about 13 years. And about the last 8 years, I've been almost dealing exclusively with seniors. And so what I'm seeing is that as they are, mostly I think what I'm seeing is when there is a pause or decline and maybe they're not coming into the clinic or I'm not going to their house, the strength that they lose is pretty quick. So what I like to see, even if I don't come for 2 weeks or something, I'm starting to see that there is a decline in their strength different from what their baseline is. Really what I'm liking to encourage the patient is you need to kind of commit to a program that's easy enough for you to do every day to try to maintain a level of strength that can prevent you from increasing your risk of falls. A lot of times I see as they get weaker, they are having more difficulty with walking for longer distances. Their stride length tends to get shorter. They're having more difficulties maybe going up and down the stairs to their bedrooms. And so now we begin to think, well, as you're getting stronger, maybe it's a better idea for you to maybe move downstairs if that's an option for you. So really what I'm just seeing is the less active they are, they tend to lose their strength a little bit more quicker. But once we are able to get them on a consistent program, it has been shown that they have been able to kind of maintain this level of strength that keeps them, their risk of fall a lot lower and being able to do things more independently.
So, specifically, what are the diagnoses that you're seeing? Are you seeing like poor balance or
Oh, yes. So decreased balance, general weakness, osteoarthritis, post-stroke, Parkinson's, conditioning from being in the hospital, things like that. It's probably the most often what I'm seeing.
Awesome. Thank you. So, and
You're
one more,
welcome.
I guess, follow up to that. If someone is feeling like they're having some muscle wasting, and they, of course, they go to their physician. What kind of things could a therapist or maybe some specialists in healthcare, who should they seek, and maybe what should they ask their physician to get so that they can get the care that they need?
Definitely. So if you're experiencing any kind of weakness that, maybe has a little bit more than what you've been noticing in the past, I would definitely reach out first and foremost to your primary physician to just test if there's anything else going on. Different things can present as muscle weakness. And so, whether it's like you're having some other kind of disease process, so you want to kind of rule out everything else. And if you can rule out most other things, then it's just could be ruled in as just this age-related sarcopenia. And so maybe the first good step is for them to refer you to physical therapy to start comprehensive exercise program, and maybe also referring you to a dietitian. It's something that could be beneficial as well. So they really can examine your diet and give you recommendations that would also help get you stronger. So I would say those are probably the two I would start with, maybe dietitian and then of course physical therapy.
Awesome. Thank you so much.
You're welcome. I'll stop screen sharing now.
Well,
Let's see.
I want to thank you guys for tuning in. And tomorrow we are having Dr. Rosette back again. So I'm really excited that she will. Dr. Rosette, you still here?
Okay,
Sorry,
I can hear you.
Yeah, so I just wanted to thank you again. And with tomorrow, we're going to have our panel discussion about allied health and really kind of go into detail about what it takes to become a member of the healthcare profession. We'll have a kind of a vast diversity of last try.
Okay.
We hope you can join us.
Yes.
Thank you again. And Dr. Rosette, I'm so happy you were able to join us today. So
thank you. I enjoyed myself, and see you guys tomorrow. Have a great day.
All right. Thanks. Have a great day. Bye.
Bye.